So thanks everyone for joining for this second webinar series on pharmacotherapy and pharmacy and medicines. We got Nick back again to do this session, and so it's such a crucial session. So thanks for everyone joining. I'm going to fire some questions out at Nick at some point, and also if you want to make any comments, you'll feel free to put the information in the chat box down there, and I'll try and answer those. I'll try and put those questions to Nick, or Nick will answer them. And if we find that there's a lot more questions than what we can cover in this half an hour block, we're happy to run a second session on it, even if it's a question and answer. So make sure you get something out of it. Before I start, obviously, we'd like to acknowledge the traditional owners of the land, past, present, and future. We also like to if I could go to the next slide, Nick. We also like to acknowledge people with lived experience and their carers, because we wouldn't be here doing all this training if that wasn't the case. So without further ado, I'm going to hand over to Nick to say hello, and then we'll see how we go and fire some questions. Nick.
Hey guys, really great to be here today. And I think what I'll start off with is around if you're thinking about your clients, when an opioid has efficacy in their treatment. So opioids are used for a number of different indications. It might be moderate to severe acute pain, cancer pain, palliative care, end-of-life care, and also for opioid replacement therapy in substance use disorder. So opioids have a place in therapy, and they have high quality evidence in those indications. And where we're seeing a lot of change in the literature is around the use of opioids in chronic non-cancer pain. And there's quite a lot of concerns around the use of opioids in chronic pain. There's a number of different guidelines that are available out there discussing therapy, or what should be a treatment guideline for trialing opioids in chronic pain. And most of the evidence suggests that they should only be used short term and at a low oral morphine equivalent. So ideally less than 50 milligrams of oral morphine equivalent daily. And there's this sort of balance that we have to really think about as clinicians when thinking about opioid therapy in someone with chronic pain. A lot of people are not going to be able to tolerate the medicine, or over 50% won't tolerate the medication, and only a minority of those patients will have some sort of response to that opioid therapy. And I'll sort of unpack that a little bit more. So drug therapies really need to be redefined, not only in the patient's mind, but also as health practitioners. No analgesic drug, unfortunately, works really well in persistent pain. And of course, we need to have that individualized multimodal approach, which addresses not only the biological reasonings for their pain condition, but importantly, those social and psychological contributors. I just wanted to share this research by Monash University. I put the QR code there, and this was looking at workers' compensation claims cases for lower back pain. And there was a pretty strong correlation to say that the longer the duration the client was on opioids for would be the longer amount of time that they were also off work. So have a read through that. It's a really nice infographic and sort of states all of the information about opioids. And Ange, have you got more questions?
Yep. I've got them all here. So the first question is around an update on the current evidence for the use of opioids, especially in pain. Is there anything further than what you've just told us that you want to elaborate on?
Yeah, that's probably a pretty good snapshot of where they're indicated for. So just remember, there's different types of conditions that opioids are indicated for, and they have strong evidence, which was listed on that previous slide. And then in chronic non-cancer pain, I'm going to go a bit more into the evidence around the risks and the benefits for chronic pain.
And Nikki, do you have a link to this article? Was that the infographic? I've seen this infographic online a few.
Yeah.
Is
So that's the QR code that will take you to the infographic, and then there's further, the article is attached down the bottom of the.
Now, I also know we've had discussions around opioids and, you know, doctors all of a sudden being forced to get people off opioids, and we've shifted the needle completely the other way, leaving people stranded. Do you want to give us a bit of a understanding of that and what that trend has caused? Because obviously there's a lot of stigma and perceptions that people are addicts if they go look for a doctor to give them because their current doctor won't. And I think it's a really important part to talk about, especially with clientele that we work with, whether you're an op rehab provider or a treater, because often people come and say, I can't get access to my medication.
Yeah, and it is something that we have got some research in America that shows probably the first research into the effects on a patient from tapering their opioids. And in America, that is totally an opioid epidemic. If you've watched or read Dope Sick before, it's quite frightening what was happening in the pharmaceutical companies who were pushing opioids. So they have now real-time prescription monitoring systems, which is similar to what is happening in Australia as well. And there is this push to reduce or taper medicines. And a lot of the time it's not done in collaboration with that patient or with patient consent. And this one study of research showed that tapering someone off their opioids was 3 times more likely to cause significant harm to them, and that was either death or opioid toxicity and hospitalisation. So I'm going to talk a little bit more around how to manage opioids in a patient-centred view, because if you don't have patient consent, it's really harmful to the patient, and you're probably putting them at more risk than continuing that opioid therapy as it currently states. Yeah.
Beautiful. And I guess that leads on to the next question around, I guess, what most of us would want to know about the risks and benefits of opioid therapy in chronic pain.
Yeah. So there are a lot of risks associated, particularly with long-term use of opioids. And I'm going to spend a bit of time today explaining opioid-induced endocrinopathy, opioid-induced hyperalgesia, osteoporosis. A lot of people are aware of the sleep disturbances, cognitive decline, sedation and falls risks that happen with opioids, but not so commonly well understood is this endocrinopathy and hyperalgesia. When we're looking at the benefits, there is the Cochrane systematic review, which we look at as pharmacists to see it's probably the highest level of information that we have around the efficacy of a medication. And so what this Cochrane systematic review does is it takes all of the randomized controlled trials of opioids for chronic back pain or chronic pain, and it pulls and makes sure that they're a substantial randomized controlled trial to evaluate if this was effective or not. So that's been available in the literature for quite some time. And what they found in the headline was basically that opioids do provide a small but significant improvement in pain scale and also physical functioning. And probably if you just read that, then you'd be kind of convinced that opioids are quite effective for managing someone's chronic pain. When you look a little bit more into that systematic review, most of the randomized controlled trials that were included only lasted for about one month, 3 months, or at the maximum 6 months. So we didn't know we haven't had any other trials that look at this on a really long-term basis. And then when they're talking about a small but significant improvement in pain or physical functioning, I think most of us would probably say, actually, that's not really very significant. So for a pain improvement, they used the visual analog scale, so that 10 centimeter scale, and the small but significant improvement was a 0.69 centimeters reduction in pain experience with opioid therapy. So when we are talking about a significant pain reduction or a significant functional improvement, usually we're aiming for about 30%. So if we're looking at 6 out of 10 we would hope that the client has an improvement by at least 4 out of 10 in their pain experience, or an improvement in their functional conditioning. So if you're looking at just treating someone with an opioid, and they say my pain is a 10 out of 10, they might get a reduction of a 9.4, 9.5 out of 10, which, you know, it's up to the individual to understand, to get their understanding if that's significant improvement. But I think most of us would say, with the results that we're looking at for clients, is that we want to have a level of pain that is manageable to live with, and also return to work, which in my understanding is around that that 4 out of 10, 3 out of 10 pain experience, and an improvement in function.
Nick, do you honestly think that someone who we focus on just on opioids with that sort of 0.6 or point, do you think, is there evidence so that they actually noticed a change in pain levels, or is it more just a calculation that came up with that sort of number, you know?
Yeah, I think a lot of the, like we have induced, health professionals have induced this reliance on opioids to manage the pain experience. And many of the clients that I work with, they say, I can't have nothing, like no medication to manage my pain experience. And there's certainly other medications that we can look towards trialing to see if they have efficacy. And I guess one of the biggest issues that I'm finding is that medicines are probably not monitored on a regular basis, and also they're not validated with a validated tool such as like a pain self-efficacy questionnaire, and goals of therapy are not included in that patient's strategy. So they're kind of put on these medicines and continued, and then they become tolerant to them, then they increase them. And it's very subjective of the patient's experience whether or not that is improving their experience, which is not the best indication. We need to have that subjective, objective, and then also that goals of therapy as an important way to validate if that medicine is improving their pain experience.
Awesome. I guess I'll move on to the next question in terms of the long-term side effects of opioids that are not so well known.
Yeah, so I was talking about the risks of opioids previously, and I wanted to focus on the not so well known long-term side effects of opioids. And when I'm saying long-term effects, it might surprise people. They might be thinking, you know, an opioid for a year is long-term, but it's really taking an opioid for every day for a month is long-term, and at a dose of around 50 milligrams or more oral morphine equivalent. That's where we see this sort of tipping point to where people will start to experience these kind of effects, these systemic effects. So it can happen pretty quickly. If you think about a month, we're already in April, aren't we? And it's 2022. So opioid-induced endocrinopathy, opioids don't just work, you know, opioid receptors are all throughout the body. And when we ingest an opioid, they have these systemic effects. And that's because there's high density networks of opioid receptors found in the brain, the spinal cord, the peripheral nerves, and peripheral tissues like the gastrointestinal tract and immune cells. So commonly people associate opioids with constipation, and that's because opioids slow down that motility when we ingest them. This image here is of the hypopituitary axis, and we know that there's new opioid receptors all throughout this axis. So if someone's not taking an opioid, what generally happens is the hypothalamus will secrete the gonadotropin releasing hormone, which stimulates the pituitary, which then allows the release of luteinizing hormone and follicle stimulating hormone. And this will increase levels of estrogen and progesterone or testosterone. When you add an opioid to this HPA axis, opioids will actually indirectly or directly reduce testosterone or estrogen and progesterone. So in my experience with clients, I've seen, you know, males who are in their 30s who have castrate levels of testosterone. And females who are actually of my age and they're experiencing menstrual irregularities, some of it even experienced hot flashes. And I've even experienced one client who was being prescribed hormonal replacement therapy for hot flashes, but no one was looking at the opioids to say, is this potentially contributing to all those hormonal irregularities? So if you think about, you know, the functions of these sex hormones, they're incredibly important in our homeostasis, and reductions in sex hormones is highly linked to causing depression, anxiety, fatigue, and then we send them to a physiotherapist or an EP or an OT to do, you know, increase their muscle mass. But with reductions in testosterone and estrogen, we have muscle atrophy, and we also increase the visceral fat. So you might be having some clients who are highly fatigued, low motivation, low mood, and challenges in actually engaging with a physiotherapist or a EP in exercise and rehabilitation. And sometimes these medicines can become a huge barrier to that rehabilitation and potentially that return to work.
I think that's a really important point there, Nick, because certainly when you were going around the country doing the training on this a few years back, and I was just tagging along with you, one of the key issues, I guess, is that often people with chronic pain or persistent pain gets referred to exercise and physio and a functional sort of conditioning programs. But if they're on a high dose of opioids, then what's the point of those functional conditioning programs really and impact? And sometimes we see that because we get these programs and then you have a second lot of programs or an extension of the program because the gains aren't there, but we actually haven't targeted the pharmacotherapy aspect of it and the impact of pharmacotherapy. So
yeah, absolutely. And that's probably a good indication of why in that Monash research, people who were on opioids long-term had a challenge in returning to work or a longer time spent not working. Yeah.
Because the mood and physical function gets impacted by the sounds of it. So yeah, great bit of info.
So, about 50% of patients receiving long-term opioid therapy have been cited to have low bone mineral density. And this is from a number of different factors. So we know that opioids can cause that sedation, dizziness effect, which increases your falls risk. And then they actually impair osteoblast activity. So the osteoblasts are the ones who rebuild that bone density. And then we know just before when learning about endocrinopathy that they reduce the sex hormones on that HPA dysfunction. So there's a couple of reasons why opioids are associated with osteoporosis. And I would say it's quite high risk. And then it's something that's not really screened for in general that I've experienced. And also osteoporosis or osteopenia is one of the leading causes of why people start to experience pain or increases in pain. So you might have some patients or clients that you're working with that, you know, their pain is starting to worsen, and it might be a lack of screening around osteopenia or osteoporosis. And then this other phenomenon, which isn't well understood or well understood within healthcare or well screened for, is this opioid-induced hyperalgesia. And it's defined as a state of nociceptive sensitization caused by long-term use of opioids. And particularly we see this in chronic pain, but we also see it in cancer pain as well. Basically what opioids are doing is they're switching on those immune cells called the microglial cells that sit within our nervous system. And those microglial cells, they increase and amplify pain signaling to the brain. So they're making the nervous system highly sensitized. If you're suspicious that a patient or a client of yours has opioid-induced hyperalgesia, basically a good way to sort of figure this out is asking them around their pain experience. Was it localized or has it become more generalized and diffuse? And they would have this enhanced pain sensitization, so allodynia and hyperalgesia. Generally with an increase in opioids is what I've experienced with clients, is that okay, your pain is increasing, it's getting worse. So theoretically, if we increase the opioids, that will reduce your pain experience. When you do actually increase the opioids, that enhances their pain experience. So a decrease in opioids will reduce that amplification in pain. And it's not, just medications like morphine or oxycodone, endone, those kinds of strong opioids. It's also seen with opioids like codeine, so Panadine Forte, those types of medicines. It commonly occurs there if it's being used long term.
And I think, and that's the thing. So in general terms, we've certainly seen this, and this is something we were trying to train other health professionals even 10 years ago, was the fact that, and they did the first sort of studies on rats, and they showed this, where you think that, and the common narrative is that, oh, your body's just getting used to it, we'll just bump up the dosage, and it actually makes people worse. So if you've got a client who are noticing that although they've been bumping up the dosage, that their pain's getting worse, it could be a result of this, and it's really important to get this reviewed. So yeah. I guess I'm mindful of time, so yeah, good. I'm going to move on to the next slide, which is around, what can we do to manage opioids?
Yeah. So earlier you asked around management of opioids, and I said that this is you need to have experience in this area, and you need to know what you're doing, because as I said, you can cause a lot of harm to a client, and that could be as bad as death. And I've seen this in practice where people don't know what they're doing, and going ahead and either tapering opioids, rationalizing them, trying an opioid rotation. And so you do need to be experienced, particularly in this area, and also be able to support GPs and other specialists or health practitioners in understanding how to do opioid management. So ideally, a gradual taper or rationalization of those opioids is where I generally start with clients around discussions with them. And this is always a patient-centered conversation. I think in the previous webinar, I talked about the brand model, benefits, risks, alternatives, and what if we maintain you on the current therapy of doing nothing. And so I always have this conversation with patients, and I get a really good understanding first of their pain experience, and potentially screening for those long-term side effects of opioids, and explaining to them what an opioid is actually doing to their system and how we can manage that. So gradual tapering plans, I would never reduce someone's opioid or oral morphine equivalent by more than 10 milligrams per week at maximum. I usually do it from 1 to 4 weeks, depending on the person. Rationalization is more around looking, some patients or clients have been on multiple different opioids, and rationalizing to one particular opioid for chronic pain. Opioid rotation is also a really good strategy if the client is not ready to withdraw or taper altogether from their opioid and cease that medication altogether. So opioid rotation I have as a plan so we can at least reduce the total oral morphine equivalent of what they're taking. And basically when you're, there's lots of differences between all of the different types of opioids that are out there. So no opioid is the same as the other. So we can rotate from one type of opioid to another and reduce their total oral morphine equivalent. And then it's a sort of like a new molecule into the system. So generally they have a better pain, they're not as tolerant to that agent, and their pain experience is improved by rotation. For some clients, there is sublingual buprenorphine, which can be used as a way to taper opioids in quite a quick manner, so over a 4 to 6 week period. That would really take the involvement of a specialist or a GP specialised in that treatment, along with, myself or Manya as a pharmacist to advise them on how that occurs. And generally that would be a regular ongoing appointment that we would have to see that client every couple of days whilst they're trialing that buprenorphine treatment and tapering their other opioids.
Can I get you to come back to opiate rotation? I've heard you when you present use a really incredible analogy on the dining chairs and the table, just to explain what your opioid rotation means. Do you want to go through that?
Sure. So if you look at, if you're able to look at a new opioid receptor, there's basically 7 different sites that an opioid can sit on. And I explain it to a client that, you know, there'll be 7 different chairs in the on the dining table, and we've been sitting on the same chair every day for the last, you know, 2 years or whatever it is. And so the chairs become frayed, it's old, it's not comfortable anymore. And so if we introduce or we go and sit on another chair, it's more comfortable. And that sort of explains to them that they've had this same molecule in their system that's created this tolerance. And then if we introduce a different molecule, hopefully that will reduce their pain experience and they won't be tolerant to it. So I use that 7 chairs sort of analogy as a way to explain how rotation works in sort of patient-centric, friendly manner. Yeah.
It's a beautiful analogy. I love it. Awesome. That's about all the questions from me. Have you got anything additional to talk about?
I would also recommend have a look at these resources. So if you have any clients who are taking opioid therapy long term, this is a great resource to discuss with them around naloxone therapy, and this is available over the counter at pharmacies. And there was a recent study that saw that naloxone therapy saved 3 lives every day for people who were taking opioids. It's really important that we get the language right, because some people think that this is associated with someone who's using illicit opioids like heroin. It's a risk if you're taking an opioid that you can experience opioid toxicity and be hospitalized. So this is a safety treatment basically. And particularly if your client is tapering, or, you know, a pain specialist or GP has recommended to taper and reduce opioids, that's probably the highest risk point when a client could be at risk of opioid toxicity. And this is really the time that they should be thinking about naloxone therapy. And also, so what naloxone does is it stops you from having an opioid toxicity event, so it reverses that opioid toxicity. So really important thing to think about with your clients, if you see that they're taking opioids long term, or if they've got a tapering plan underway, just asking them, have you talked to a pharmacist or GP about naloxone? And I can send you some resources. Yeah.
Awesome. Nick, yeah, any questions from anyone that's attended, put in the chat box. We're almost out of time, but we're happy to obviously stay back for another 5 minutes or so. Thanks so much again, mate. A really great, you know, fast, rapid sort of presentation and insightful presentation. So we really want to continue this. If anyone who's new to our services or don't know much about us, Nicolette and Manya are both pharmacists on our team that we collaboratively use them as part of our sort of pain assist program or fatigue assist or cancer assist programs. They do pharmacological reviews, write a report to the GP with recommendations. They don't just say they need to change medications or rotate, they actually then give a plan for the GP to follow. Often we use it as part of our holistic approach, and both Manya and Nick have said that that works better for them because they can talk to us, get further info if they need to. They're not going blind to see a client, but we also do utilize them, and some of the insurers have utilized them as a standalone service. So if there are clients or you guys think we could help, feel free to reach out and let us know. You can email me directly or just email info@beyondpain.com.au with any sort of questions. We got some people in the, we got some comments in